Hi all, this is the recorded lecture for the first day of pediatrics. I'm recording it so that you'll have it available to you. First off, recording disclosure. You guys know this by now. Anyways, let's start with chapter 1, Perspectives of Pediatric. Pediatrics has come a long way. Like, for example, from the day when I used to be a nurse in peds to now, it's totally different than what it used to be. Okay? Um, things have changed quite a bit. Now, I wasn't in this era of nursing. I still remember this would probably be about the time my mom had her appendix taken out, right? Anyways, long story short, her parents dropped her off at the hospital, came and picked her up when her surgery was done. It was a different way. When I first started as a nurse, parents were viewed, family was viewed as visitors. Visiting hours were over at 8, everybody left. Those of you that are parents or have young children in your families, can you even freaking imagine leaving a baby there by themselves or a child that can't communicate for themselves? No, would be my answer. So we've come a long way. Now parents will stay with the child. It's almost expected that they do. I mean, it's not mandated, but many parents will stay because they know their child feels much more comfortable with them there. So, like in this video, you see some parents and stuff. Yeah, they're there. I have done almost everything in the care of a kid for a kid with the parents present, including coding a child. So again, they are so important in their lives. This is foundational to family-centered care. What is our goal? Here is it right here in a nutshell. FYI, we take care of children and their families. We advocate for them to have a healthy lifestyle. Primarily, yeah, those kids are my patients, but the whole family is who I take care of. Why? This little baby, this little girl do not come with owner's manuals of what to do, right? We rely on family members to help us or whatever, but we as nurses can teach families growth and develop. One term you will hear used frequently through this course is anticipatory guidance. What is that? It's how we teach families, okay, for example, you've got this cute little baby in your arms, not really, getting around very much. Well, life's going to change, and here's what's coming up next. And this is how we keep them safe at different stages of the game. Okay, some of our goals for pediatrics, of course, as with adults, we want to promote their development. Sorry, I said the same as with adults. No, children are different. 5 of Erickson's stages out of 8 apply to children. Those 5 stages you need to know like the back of your hand for the test here. Yeah, we will promote development at every age and every stage. This is foundational. We'll speak to this quite a bit in this course. Nutrition is foundational to the care of children. We go to Head Start with some of our rotations. The premise of Head Start is this: you feed them good, healthy meals, they're going to grow. They're going to grow appropriately. It's like outside food is not allowed in Head Start usually. Halloween they'll do like a trunk or treat or something like that. But with that said, no, you can't bring in stuff like you could at like a is why it's very controlled, their diet and stuff. I don't mean controlled but very like it's balanced. It's balanced food and they want the kids eating that. This is a big one in peds. It's a big one in my life. I tell you, you guys probably think I'm nuts or cuckoo about teeth. I'm going to tell you this. Teeth are hugely important to people. Hugely important, meaning that this is one of the most preventable chronic diseases of childhood we can do. By taking care of those teeth, we'll go over that in just a bit. Nutrition, teeth, promoting development. You know it. All right, here, the art of family-centered care. I crack up because I worked with people, taught with people who do med surg. This is where I used to work, not here. And they would say, "Oh, the patient is my primary, concern. I don't deal with the family." Well, now we're sending people home sicker and sicker. Y'all are dealing in the family with the adult world. We have dealt with families all throughout pediatrics. Let's put it this way. People will tell me, "Oh my gosh, how did you ever work peds? Those parents are freaking crazy." You know what? That's part of what I do. When I get these families now, if you think about it, you guys, if a child has an acute illness, something that just happened, a lot of times it's because we took our eyes off the ball, right? Long story short, the families can be shattered. It's my job to get a kind of piece them back together through this, enabling and empowering them to help them resume their role as parents, as caregivers. Very, very key to pediatric nursing. Look how young Sasha and Malia are there. Oh, they were so cute. But here's another concept you need to know about family-centered care. Who is the family? It's whoever they say they are, right? Here's a story I always share with people because it cracks me up because it was back in the day before we were into like we knew about transgendered and people who didn't recognize their birth like gender so to speak um as themselves. They felt differently, right? I had this baby come in and he was about I think about 2-ish. And anyways, the mother you like have one foot out you're in Pete's ICU with your kid. One foot out the door, right? I asked her questions. She didn't know answers to it. I'm like looking at her going, and I lump people under this umbrella. I'm like, okay, crackhead, who takes care of this kid? Because the kid was in excellent shape, growing, all within his parameters. Long story short, she's like, can I go? Yeah, fine. And walks this man dressed as a woman, and this child just reaches out for him. Well, I asked him, though, being the responsible person, how do you prefer to be addressed, him or her? She identified as a her. No problem with me. I care. Who are you in relationship to the kid? He was, I mean, she was the family for this child. Yeah, I'm going to call social work in and clear all this mess up, so to speak. Get it, many times families will let someone else raise their kid without the legal paperwork, but they can handle that. My job is who does that child recognize as their family? And in that moment, he recognized her, and she had all the information I needed. What medication? What was the child's diet? Was there food dislikes? Different things like that. So just again, family who is whoever they say they are, all right? We get families in there to help people, I mean help the child to get them relaxed. Now families are not visitors. They stay with that child, okay? Cultures, religion, beliefs, well, that's who that family is. That's who supports that child. Yikes, let's see. Okay, here's those concepts. Again, they kind of get bad. Enabling, and psych is not a good thing. But yes, I enable parents. I try to get them back in charge of their children. You can look over and read over that. Here's a big one you need to know for the test for pediatrics. What's atraumatic care? Um, Traumatic care is this. First, do no harm. We do a lot of things to kids that can be harmful, that could be traumatic to them. Before, we didn't used to care about this type of thing. For example, I used to do help with lumbar punctures. Sometimes those kids would be screaming and fighting because it's difficult when somebody's holding you, still for a test. Well, I'm going to tell you what, now they'll sedate children and stuff. So we've come a long way. One thing you need to know is this: their rooms, their bed in the hospital is their sanctuary. We need to respect that space. Yeah, you can do vital signs in the room, but don't be doing like blood draws, IV starts, that type of thing. Another thing we need to do is prepare children for procedures in a way that's developmentally appropriate. You need to know, like a little child like this, a preschool age child, or she might be a toddler, I'm not sure. That age likes to touch it, feel it. They need it in the moment. So if I'm going to prepare her for, say, like a blood draw, I probably wouldn't show her the needle, but I'm going to show her maybe the tourniquet. I'm going to tell her, it might hurt for a second, but I do have a tool in my tool belt called EMLA cream. EMLA cream is this. You can put the cream on the skin. EMLA, LMX is another one, and it numbs the skin. Problem with EMLA and LMX cream is EMLA cream has to be on for an hour, LMX about a half an hour. They're both like a lidocaine based or prilocaine based um, numbing cream, and boy, oh boy, it does work. Biggest thing is I put it on a couple spots because why? If I miss in one area, I know I got another area to go to. All right. So that's a big one. Know about EMLA cream for the test. Put it on wherever I think I'm going to be poking that kid. I know I have to do it prior. The other thing is this, after the procedure's done, I'll use that FACES scale to figure out, did it help you? Did it make it less painful for you? Pain prevention is key. Another thing is positioning. An infant is going to like to be, most infants, like 6 months and under, like to be swaddled, given something to suck on while they get that blood draw or whatever the traumatic procedure could be. They also like to be held and held close during that. Many times, if I'm drawing a baby's blood, I tell the mom or dad to hold them close after I bunny wrap them, swaddled them, or whatever you want to call it, and then get them to suck on this pacifier or this sweetie they're called. It's a little nipple that's like populated with some sweet stuff on it, so they'll suck on it. But again, that's very important to know with little infants. All right. Okay, our job is this to advocate for not only the child, but the family. All right. Next up, here's some issues that children could suffer from. And we're going to go over through many of these, but you can kind of see there's a lot of things that affect children. Healthy People 2020, now you guys all know we're in 2030, but the Hockenberry book we're in still uses 2020. What's the goal? Remember, 2020 is to try to help populations be healthier. And these are some of the frameworks of that. Other things are, these are those remember LHIs? You learned that in 222. Here's a big one for peds, immunizations, right? That has changed the whole course of pediatrics. We'll get into that when we talk about immunity and communicable diseases, but honestly, there used to be a pediatric unit in every hospital around, every community-based hospital. Now, not so much. Look where we, have uh, places to send you. Very few. I worked at St. Joe's in Pontiac. That PAGE unit was very prevalent. And in the winter, we would get 30, 40, 50, sometimes even 60 kids. Now they're lucky if they get like 10. But that's a good thing, right? Largely because of immunizations. Okay, what do we know? Anyways, we look for every opportunity to provide healthcare to children, equal opportunities for all. Remember again, hang on 1 second, let me pause. This is kind of important to know about children is what are they with their development. In files, you will see, I always tell you guys, growth and development is key. In files, you will find a form. Let me go here to our files and open it up. In the handouts for week 1, you will notice some growth and development information. All right. Here's some study guide tasks. So in This is important. I would print this off. You're going to see some of this stuff again. Gross motor skills and fine motor skills, what they should be doing. And the infancy period is when they grow the most. Why do I care? Well, let's talk about this for a minute. So, about 4 months old, don't have head leg anymore. It's gone. Well, let's say we've got a kid who's 10 months old. When I lift them up by their arms, like pull them forward, their head lags. We have a problem. Again, all these need to be reached as they go. All right. Here's a big one. This one you will always need to know right here. 8 months old. They sit unsupported. That means if they're 11 months old and I go to sit them up or they go to sit up and they're flopping over, something is not right. All right. So, with that said, this is so critical to know. I'm going to tell you, you guys, I would use the ATI book as well as this sheet is good. Why? Hockingberry, in my personal opinion, for infancy is just too much. It's overwhelming. This form here, as well as the ATI book, hit on some of the biggest hitters in pediatric growth and development. All right. 'Cause look, we'll have a crude picture grass. That's a young baby. Remember, when they're first born, their fists are kind of clenched, and as they grow, they get less and less. Here is a pincher grasp. Look at here. Where is it at in the thing? Usually by about 10, 11 months, they will have a pincer grasp, meaning they pinch up things to pick them up. All right. Here's a big one too. I mean, you can see the development slows down over time. This is a big one too. No, this one stands on. You're like, really, Kearney? Stands on a foot for 3 seconds? Yes, that's a huge developmental task. If you think how this younger baby walks, okay, 15 months, by about 12 months, they're walking independently. They'll take a couple steps, they're wide stance, and they usually fall down, right? So, with that said, just some things to be aware of, okay? Why? If I know deviations, I am no developmental expert, but I can recognize you're 11 months old, not sitting up with, I need to prop you up with 3 pillows to get you. We got to ask somebody about it. We will, ask the provider what's going on here. Should we send this kid for developmental investigation? There are some stages of development. Infancy is the one they are just changing day by day almost, it seems like. Toddlerhood, we'll talk about these in the next video, but that's a real interesting period. Those of you who have a toddler will know. Early childhood, please divide that between preschoolers and school age children. And then, of course, our adolescents. Okay, here's how kids grow. Again, from head to toe, cephalcaudal, all right? And from proximal to distal. So remember I told you they have that crude pincher grasp, then it develops by about 10, 11 months to a fine pincher grasp. Yeah, they are, the muscle and nerve development is coming outward, so to speak. All right. There's a reason we can't potty train an infant. Their spinal cord isn't fully myelinated yet. Like their legs, they can't walk and stuff just yet. As that spinal cord, as things are developing, they will get more strength and more nerve like function, more voluntary function, right? So, just some concepts to think about with growth. FYI, infant can't stand, say, even up to like 2 or 3 year olds, we use a recumbent, meaning a lying down um, way to measure them. Why? I can't put this baby on a scale and like have them stand up and turn around while I do their height, like you guys would as adults. No. So I want you to know this. When we measure them, usually I'll ask the parent real quick, lay them down either on the treatment room table or on the bed, and I put a mark at the crown. Then I straighten the foot out and put a mark at the heel. And I say, okay, come up. And then I measure that area there, and that will give me a height. Weight is usually done on a scale. Now, I believe our book says weigh in without a diaper. I'm gonna tell you this, there ain't one pediatric nurse who does that. Why? This kid's gonna pee all over the place, right? So with that said, usually I change the diaper, put a dry diaper on, tear the scale with a dry diaper on, get rid of on the scale to zero it out. You get the drift on that one. But usually development does occur in an orderly sequential pattern. Not all will achieve them all at the same time. I mean, we all know babies that walk at like 10 months old. That's really early. But with that said, that's okay, right? But many times we want to make sure by those like dates on that form, are they meeting those? Some things are going to affect our growth and development. Heredity is one. You're not going to be Shaquille O'Neal if that's not your dad and mom, right? If you're a small person, usually your children are going to be the same. Remember, nutrition is hugely important in childhood. So, so, so important. Why? That's going to help their brain develop, their body develop. And here's what you need to know for nutrition, want it quality over quantity. All right, we're going to talk about that further. Here's one thing that you're going to know by the end of this course. Disease. Disease, if the child especially has a chronic disease, it's going to affect their growth and development. So as we go through the different systems, you'll see a kid with chronic heart disease is going to be what we call, hey, oops, that's like a bad looking F, but I was going to put FTT, failure to thrive. All right. And we'll talk about that further. But usually kids with chronic disease will be small for the issues related around their disease. Okay, other things, environmental hazards, stress in childhood. We know right now having the schools closed down during COVID was extremely stressful on children, but it was not, we couldn't prevent it. I was watching an interview with Dr. Fauci, and, hindsight's 2020. Should we have had the schools closed as long? Who knows? You know what I'm saying? Like he was saying, 1,500 kids died from COVID, way lower number than adults. But was that because we closed the schools and they weren't interacting with each other so much and their family members were at home? So just some things to think about before we jump on those bandwagons of criticizing. No, that was a pandemic, you guys. Very, very real situation. Remember, media, this is where I always challenge you guys. We got to teach families. You got like the news on 24/7. It will affect the child. You think they're not listening? They are. And if you think of video games and cartoons and stuff, the character dies, but then they jump back up. That's going to reflect in children and how they think. Okay, here's nutrition in infancy. I just love, love, love this picture. I love her hair. I wish I had the guts to do that to mine. No, I'm just kidding. Here's what you need to know. You may have learned it from me with nutrition if you had me. Breastfeeding is best, period. Mom's milk, and this is what kills me that people get so freaked out about breastfeeding. We watch a cow breastfeed their children, right? A baby calf. Breast milk is made for humans, right? But with that said, not all people are able to breastfeed. If they cannot, this is the next best thing, iron fortified formula. That's why that formula shortage was such a big dealio. They need to drink that for up to a year. Why? People were, well, why can't we just put them on milk? No, milk is not a good source of iron. An infant, where is the bulk of their calories coming from? From either breast milk or formula, right? So, mom, I can have her still take her prenatal vitamins, and that will give the baby iron. Iron fortified formula is going to give that infant iron. All right. We put them on milk, or, my mom, grandma's. Oh, they should just go back. They used to mix pet milk with evaporated milk. No wonder we all have sugar addictions, just saying. But with that said, no, those are not appropriate and nutritionally sound. Okay. Formulas do try to mimic human milk as best as possible. Other thing you need to know about feeding children is this. Family asks you, can I give them fruit juice? The answer is no. Usually around 6 months of age is when we start introducing solids, and you know what that means. Small amounts of solid foods. Don't want them having a whole lot of fruit juice. At 6 months, they could start fruit juice. We're not replacing any of the bottles with it, okay? Get that? They need that breast milk or the iron fortified formula. Okay, other nutrition in childhood, as that child grows, we know that toddlers become really picky eaters. This is real interesting. Lifelong eating habits develop by age 3. Here's what you guys need to know and what you need to teach parents. Okay, mom and dad, if you're a picky eater, do not share that with your child. Like I never used to like tomatoes, but now if I had a kid, I'd be like, these tomatoes are so yummy. Even if I faked it, acted like I was eating it and didn't, or choked one down, right? Yes, the thing about children, again, 2 years old, they start becoming those toddlers, they don't eat anything. What you need to do is keep offering them quality foods, all right? I had a student, she's now besides being a nurse, she's a life coach. She was telling me her baby, ate everything. She made all her own baby food because she was very natural, right? Long story short, she said, "Oh my gosh." She became a toddler and it was like a nightmare. She goes, I'd put that spinach, raw spinach on her plate. She wouldn't eat it. She said, but I didn't make an issue of it. I just kept putting it on her plate. And eventually she tried it, liked it, and now she asked for it. So long story short, keep offering quality foods. Here's where I like lamb base, what you call it, kids meals at like restaurants. Please, you guys, bump out the extra money for a regular meal and split it between your children. Why? It's abominable. Ugh, I didn't say that word right, but it's terrible what we feed kids. Fries and chicken, fingers. Come on, they can do better than that. Offer them quality foods, right? We also know there's issues around children that are homeless and things like that. Dental care. Again, I'll be harping on the teeth a little bit. Sorry. It's This is what you need to put in your brain right here. They are preventable. They're a chronic disease in children. We do not want their teeth looking like this. This is their baby teeth, if you will, or deciduous teeth. Up in these gums is that primary teeth. You can rot their teeth, it will travel up into the gums and rot the primary teeth. So, with that said, what do we need to teach parents? Dental hygiene begins with that first tooth eruption. You either brush your child's teeth or minimum wipe them down with a washcloth after they eat, just a wet washcloth. But ideally, we should be brushing their teeth and, of course, using a small amount of. And the reason why they have children's like um, toothpaste is there's not as much fluoride in it and different things. Because why? We know kids don't spit out that toothpaste, they swallow that down. All right, remember fluorinated water. If they're living in a city dwelling, they're getting fluorine in their water. If not, we're either supplementing it or the mom's taking it if she's breastfeeding. Look at this. This is a big change. Used to be that we said dental visits start by age 3. No. By 6 months, once those teeth are coming out, they, starting to erupt, they need to see a dentist. Okay? Very, very important to teach parents this. It's preventable, right? Here we go. Immunizations, you know my feelings on this. And when we get to communicable diseases, you guys will be like, oh my gosh, Kearney. Yes, they need their immunization. It has changed pediatrics. Totally. Some other childhood health issues are these. One I want to point to that seems to be a real live American problem is this violence, all right? Violence, children, ugh, don't even get me started. It's just in our culture that needs to change for the sake of our children. Okay. Okay. Infant mortality versus childhood mortality. I know you're like, Kearney, really? Are recorded in different ways. I want you to know that with infant mortality, that's kids a year and under, that first year of life, usually the leading cause of infant mortality is um, congenital anomalies. Know this, please. Yeah. Why? If we were in class, I'd be asking you, why? Think about a 1-year-old. Are they getting around very much yet? Not so much. So um, with that said, it's real important we, know this. All right. Usually it's congenital anomalies. As they get older, that's when we're going to get more into accident injuries. Okay. Then there's some things that could put kids more at risk for injuries. Gender. Now, I always say, is it because we socialize boys different than girls? I don't know. But you can read through these, but a lot of things will affect, how much more is that child a risk taker? Do they have, if we're living in poverty, they might not have the money for a child seat and stuff like that, or the helmet when that child rides a bike. Okay, some stuff to think about. Okay, here we go again. Causes of infant death are congenital anomalies. So a year and under, that's the leading cause of death. Yes, SIDS could be an issue, but this one's the number one. Okay. Childhood mortality. Okay, as that kid gets mobile, here's some of the issues we will see. Accident and injuries are some of the that's their leading cause of death beyond 1 year. Remember, they're more mobile, they're getting into things. We're going to discuss that right now. Let's first talk about motor vehicles. You need to know this one really big. I have a video that's posted, and please, you guys, pay attention to the notes in the PowerPoints because I put some good information in there for you, kind of drilling it down what you need to know. But car seat safety, it is, no child should be unrestrained in a car. No person should be, but children especially. Where does that car seat need to be? Rear facing, remember? Rear facing until they can't, until they're like pushing off that seat. All right? Rear facing in the back of the car. No child should actually be in the front seat for quite a long time. Even there's some petite older adults that almost need to have their airbag turned off. So long story short, this kid should be restrained. This age, he's big enough. I'd put him probably in the booster, a toddler booster seat, but again, in the back seat, center if you can. Drowns, water is a big issue for children, one of the leading cause of deaths. I worked in Florida. I actually left my job in Peds ICU in Florida. I couldn't take it anymore. We had 1 to 2 drowns like a month, sometimes more. Everybody has water around them in Florida. Here's the problem. You take your eye off the prize for a minute, it can happen. Before you get judgmental, I'm going to tell you about a story. My pediatrician in Florida, it was a group of 3 women pediatricians. They were awesome. Their office people, awesome. Well, they had a little get together with their kids at one of the pediatricians' homes, right? So it was 3 pediatricians and pediatric office staff. A child drowned in the pool at that home. Here's, when other kids are in the water, they're kicking around, kicking around, kicking around. You can't always see the bottom. This 1, 2, or 3-year-old had gone to the bottom of the pool. Nobody noticed. The child drowned and died at that party. And again, it was a family get together. It wasn't like they were throwing down a bunch of booze and stuff. Try not to be judgmental. Burns are another leading cause for children. You can pull stuff on them. We know this pan should be in the back of the stove with that handle facing towards the back. Try not to be distracted when there's something hot going on. Hot water heaters need to be turned down to their lowest setting, which would be 120 or below if you actually have a temperature setting on your hot water heater. Some are just like low, medium, high, low setting. Their skin can burn way quicker than ours can if exposed to hot water. The next thing, sunscreen. Hello, 100% sunscreen. Make sure this family member knows to put sunscreen on these children and reapply it. They won't do it for themselves. It's our job to do it. All right? Then they become teenagers and we need to teach them tanning beds are not a good place. You're already setting yourself up for skin cancer. And okay, violence. You guys, if you have a gun in your home, I know we're Second Amendment, whatever. I don't care. But you keep those guns locked up, keep the bullets locked up in a separate location. Why? I've taken care of too many kids who shot somebody by mistake. Here's one of the worst cases I remember. The little boy, he was like 3. The dad had the gun hanging from the bed in the holster. Okay, like okay, corral style. Are you kidding me right now? Long story short, that 3-year-old whose birthday it was grabbed a gun and accidentally shot his sister in the head. She died. She was 4 years old, shot in the head by her brother. Does a 3-year-old know that? No. Now let's fast forward to adolescence. You keep those guns away from adolescents. Oxford's a big example of that. Another example is this. Keep the guns locked up and keep that either the combination or the key with you. Adolescents, here's one thing you need to know about them. They never think it'll happen to them. It's that like one split second where they kind of either, if it's suicidal or homicidal tendencies, we don't want that. Adolescence is another high risk group. Okay. Suffocation. Infants can put everything in their mouth. They're in the sensory oral phase. So everything is in their mouth. Their airways, FYI, are the diameter of their baby finger. So many things could cause them to choke. Their airway could become occluded. Plastic bags, people don't have dry cleaning anymore like they used to. But if this is a dry cleaning bag or any plastic bag, you should teach the parent, knot it up so the kid can't get it up by their face. All right. This is a big one. Poisoning. Pills, liquid, oral medications. Never refer to medications as candy. Number one. Don't these look like candy to a kid? Heck yeah. FYI, this child protection they can get into it faster than I can. Faster than I can. And one pill could be problematic for them. You need to teach parents, keep this locked up. Up high is not good enough. It needs to be locked up. You ever seen a kid this age scale like the kitchen cupboards and stuff? They can do it. Just saying. Build a tower, to get to stuff. Long story short, keep it locked up. If the child accidentally ingests something, their first thing to do is to call poison control. All right. FYI, this kid's going to see grandma and grandpa, or grandma and grandpa are watching them. Make sure grandma and grandpa know. Lock it up. Why? Many older people will have those easy open lids because they have arthritis. Or they have those pill separators. You know what I'm talking about. Those carousels of death. Saturday, Sunday, Monday, Tuesday. Those aren't locked up, and it's a whole blend of all the medications that grandma and grandpa are on. Keep them away from children. Locked up is the best answer. Okay, morbidity is just illness. It's kind of difficult to measure. You can read through this on your own. Okay, let's see. And again, you can read through this. Okay. All right, family structure. Let's talk about this real quick. This is chapter 2. You don't need to revisit this. Who cares? What you need to know is what? Whoever they say the family is the family. I'm going to tell you, see this, I loved Modern Family. That was such a good show. Before you call him grandpa, remember, he was the daddy to this little boy here. Just remember, you guys, a man can have children until the day they die, pretty much. Woman, not so much. We got a biological clock that's ticking, right? Here's how I ask people. Can you tell me your relationship to this family? Here we have two dads. Can you tell me your relationship to this child? How do they refer to you? They might call one dad, one daddy, one papa, whatever. I'm not judging. I will support them. Parenting styles can be different on how parents raise children. When they're in the hospital, I'm going to tell you this, many parents lose their freaking minds. Don't just they become very permissive. I'm going to tell you what happened to me, and this will put it forward. You can read through this stuff on your own. I had a little boy, I think he was 6, 7 years old, he had leukemia. It's that, that's sad, right? I forget what I was doing with him. It was in his room, it wasn't in the treatment room. And he hit me. He reached down and hit me. I looked at the mother like, you gonna do something about this? She did nothing. I was like, oh my God. I said, can I talk to you, with you for a minute out in the hallway? I'm not gonna reprimand her in front of her kid. I said, did you not see your son hit me? He needs, a timeout or something, right? She was like, well, I have such a hard time disciplining him because he has cancer. I'm like, he's going to survive this cancer probably. Statistics are in his favor, you know what I'm saying? Long story short, I said he's going to survive cancer and he's going to be a beast. No one's going to be around him. So long story short, we need to teach parents. They are the parents. Um, anyways, just be aware of that. All right, sorry, my phone is like going like crazy. Okay, next up, special parenting situations. Divorce is a freaking nightmare with kids. I'm just going to say children will frequently blame themselves, right? Frequently they will. Long story short, that kid should not be in the middle. That child should know it was not their decision to have a divorce, all right? That was an adult decision. Both mommy and daddy love you, all right? Teach parents, don't insult the DNA. I don't care if you can't stand him any longer, right? Doesn't matter. Half their DNA is in that child. So if you're criticizing the family, you need to know that. Anyways, divorce situations, let me tell you sometimes what happens. Families will tell you, a parent might say, oh, I have full custody. Show me what I say to them? Show me the paperwork. FYI, here's you can read through that if you want. Chapter 4, let's talk about communicating with kids. First, we're going to do adults. Parents, establish the setting. Introduce yourself as the RN. You're the person who has the knowledge in the healthcare team, right? Many times, like hospitals will have the blue, the green, the different color scrubs. Families don't always know that. I let them know, my name is Peggy Kearney. I'm the registered nurse taking care of your child today. Remember to respect HIPAA. It's a little difficult because the parents, are the people who get the HIPAA. Teenagers will have special HIPAA rights. We'll talk about in a minute. Remember, use open-ended questions with older people. Here's a situation. We've got, the nurse interviewing the mom. The kid's over here, but don't be thinking he's not listening because trust me, they are. All right, they are listening. Also include them in the conversation. Refer to them once in a while. Please, you guys, if you have a situation where somebody does not speak English as their primary language, get whatever mode your institution uses for translation. I'm telling you what, this won't be on the test. This is a game of life. I always tell you guys, get in there if the doctors come around or, the medical team comes around on rounds. Get in there and listen to what they're telling these families. Well, me and my student happened to be outside this one child, her child's room when the rounds were being done. I'm like, come on, Joan, let's go in. They were talking to this dad. This little girl was like about 18 months old with asthma, huffing and puffing, carrying on. Much discussion had been going on for this was day two. The kid was there, that they were like kept going back and forth. Should we transfer her to a Peds ICU? Well, his family didn't speak English. They spoke Spanish. What do many foreigners do? Uh-huh, uh-huh. You know what I'm saying? Long story short, the medical team leaves the room. My student and I step out in the hallway. I looked at her. I said, Joan, what do you think? Do you think that dad understood a word the medical team said? She goes, no, Kearney, I don't think they did. What do you want to do, Joan? Is what I asked her. She said, you know what? This hospital, we use this phone. She goes, I want to go get that translation phone. I said, excellent choice, nurse. She went and got it. You pick up this end, hit the speed dial, ask for a Spanish interpreter, and then you hand this end to the family. This is what is heartbreaking to me and actually just um, makes me feel just totally sad. The first question that dad asked through the translator was this: is my child gonna die? First question. I'm telling you guys, I was so angry. Why? 2 days, just about 2 full days, that man sat there worrying, was his baby gonna make it? Was his child gonna die? For 2 days, people were communicating with him, quote unquote, not. 2 days he sat in anguish, wondering if his child was gonna die. When it took my student 5 seconds to set this phone up, saying, all I want to say, you be the advocate. You get the phone. I had one student, the family was Chinese speaking. They spoke Mandarin. My student, the medical team came in the room, and I was like, oh my gosh, I just love you. They start yapping at the family again. Many people who do not speak English are yapping. She goes, oh, hang on, let me get an interpreter on the phone for you. I'm like, look at you go girl, you're like killing this clinical. Anyways, other things communicating with children, there's a nice guidelines in page 60 of our book. We are developmentally appropriate, meaning we get on that child's eye level. I speak very softly from years of pediatrics, speaking quietly with them, all right? One thing to remember is this: children, especially younger children, less than age 5, are very egocentric. It's all about them. All right. Remember, one of the best ways to communicate is use the play that's appropriate for their age group. And we're going to talk about play in just a bit. But remember, kids are very focused on themselves. That's okay. That's just where they're at. Okay. I always say this: if you don't have some freaking fun in peds clinicals, there's something wrong with you. No, you can play with your child. Play a game, draw some pictures, right? Read them a book, watch a movie. There's a Disney film you wanted to see and haven't had the time, you put it on for that toddler. You know what I'm saying? Enjoy your peds clinical. Here's some other principles. Make sure you're honest with them. I'll tell them. They say, like, I've given them medications. Does that taste good? No, it doesn't. But here, when you finish it, I'm going to give you this glass of juice to drink. You know what I'm saying? That type of thing. Make sure we give children, usually I say, never separate a child from their parents, except for if they're older, they may need the opportunity to talk without the parents present. Okay? Remember, this is a big component. We're going to talk about it over and over again. Play is how children communicate. I've had kids who were like school age kids. I'm trying to ask them questions and stuff, and they're like, oh, I pull out the coloring books and crayons, and man, we rock the house, and I get to know everything about them. You know what I'm saying? First off, infants. Their nonverbal can be very frustrating to all. With that said, here's where I wrote my parents in. They're crying. Are they hungry? I think they're in pain. Mom, Dad, you know them best. What do you think? What should I know? Okay, make sure it's developmentally appropriate. Like I told you, younger children are very egocentric, very much think that everything's about them. Another attribute, this is so important to know, they think things that are inanimate are alive. I had a real good video. I might show you guys in class. This little boy is running on a slip and slide. He's like 2, 3 years old, right? Hello. We all know you run on a slip and slide, you're gonna fall. He falls down, he gets up, he's yelling at the slip and slide, reprimanding it. It's like, dude, it's a slip and slide. He gets up, he tries it again, falls, same outcome. It's like, come on now. You know what I'm saying? Anyways, big thing to know. Another thing is children this age want to touch things, feel it, know about it, usually before you do it. You can't teach them like hours and hours before. No, in the moment, I'm going to let them touch it, feel it, that type of thing. Remember, toddlers are very ritualistic and frequently they regress. Okay, meaning that toddler who is completely potty trained might all of a sudden start wetting the bed. Kind of normal. Don't let grandma get up all in their case about wetting the bed. No, grandma. He's stressed out about being in the hospital. It's okay. We'll just get him cleaned up, get him to the playroom. He'll be fine. Like, oh, grandma. That's what I always say. School age kids. They're very industrious. Those of you who have kids in school know they have pictures up all over the place. Pictures they colored and stuff like that. Yeah, crucial to know that, all right? Body integrity isn't so important for them. What does that mean? If you give them, say, like an iron injection, take out their IV, even if you say, oh, it's not bleeding, the kid thinks they can eke out of that hole, so to speak. They'll beg you for band-aids. Just give it to them. You're not going to, they think that, like, they can actually, like, eke out of their body, so to speak. They love school-age kids, games, drawing, that type of thing. Arts and craft all day, every day. Adolescents are a different breed. I love them, though. What? What? Who's important to them? Not so much mom and dad anymore. Although they're still important, their peers are like rock the house in their world, all right? Peers are so very important for them. I had a kid who was in the Peds ICU, and I mean, in the ICU, we didn't have room in the Peds ICU. My boss, my nurse manager, could not wait to get him down to us. Why? He was actually, he's in adult ICU. His friends wanted to come visit. They're like, no, family only. Well, you know what, you guys? Um, Unbelievable, right? Family only. No, a peer needs to see him. This was a kid who got hurt at a football game. I forget, it was ACL or head injury. I don't remember what. But oh my gosh, my boss, as soon as we had an open bed, she put him in there. We had the cheerleading squad, all the football team, the coaches. These are the people important in their lives, all right? I also want to warn you, even if you're 22, you're old in their book. You know what I'm saying? Old. Me, they think I had a pet dinosaur. Just saying. With that said, remember, peers are so crucial and important. And the other thing, they think they're invincible, that nothing will happen to them. All right? When you're dealing and communicating with them, they may become angry and emotional. We got to remember they don't have quite the coping skills that we have. We've taken a lifetime to build. All right. So I've had kids call me outside my name, but you know what I just tell them? Remember that it's not appropriate to use that with me. All right. Remember, when they're older, they can be prepared for things a week or longer before, just like an adult. But again, we will respect their privacy. They may tell me things that I'm not going to relay to the parents. Okay, now let's talk about play. All right. Play is the universal language of children, is their work of childhood. It's their job. All right. When you teach a child about peekaboo, they're developing object permanence. An infant, when we cover their eyes and go peekaboo, when you cover their eyes, they think you're gone. It's not till about 10 months old they've developed something Piaget called object permanence, meaning I close my eyes, that person's still there. Here's an example, a young infant. I shake the rattle in front of them, right? With that said, if I hide it, the baby's 1, 2 months old, 3 months old, 4 months old, they don't look for it. That's object permanence. As they become an older infant, shake the rattle, hide it, they're looking for it. All right? Mom or dad leaves the room, they're watching because they know that they're going there. All right? Remember, play is crucial in children. We use sometimes something called a transitional object. First off, let's talk about that. A lovey. That's what I like to call them. They're lovey from home. They're security thing from home. Many children, it might be a stuffed animal, a doll, different things. I mean, I've seen some weird things, but whatever. It's their security object, their emotional support thing, right? Let's use this bear for an example. So it could be dolls, bears, anything. Here's how I communicate with a child. Say I want to listen to long sounds, right? I'll say, "Ooh, let's listen to Mr. Bear's long sounds," as I'm listening in my lung field. Wow, he's sounding so much better. Oh, now let me come over and listen to your lung sounds. So you can transition between the two, between the inanimate object as well with the child. And usually they'll tolerate it better. Okay. All right. Here's a big approach to know about doing um here's what you need to know about children and head to toe assessment. Unlike in 302 and 304, we don't go in the order that we taught you. Different for kids, all right? Do I do a complete head to toe assessment? You betcha. But I'm going to do it differently. Here, let me describe how it's done. We use minimal contact at first. So let's say this baby was my patient that's sitting there with, oh, just say the mom, could be some other person in their life. Long story short, I start at the door. I'll look at him. I'll count his respirations. Largely, I'm looking at his belly movement, right? Counting the respirations. And then I'm watching his work of breathing. Then I'll approach him. Usually I'm getting down on my knees to speak with them at their eye level. Quiet voice, maintaining eye contact, right? With that said, usually I'll start listening to their lungs and heart first. It's usually the less threatening. Closer I get to this head, the more threatening. This kid's quiet. I want to try to assess those heart and lungs first. All right. In our files, there's some age specific approaches, like assessment approaches. Use those. Those are very good. Okay, on to chapter 5, pain assessment in children. This is crucial that you know we can't assess pain in children like we do adults. Many times these physiological measures might not be the same as, an adult. If their heart rate, blood pressure's up, I know they're in pain, right? Not so much with children. We use several different scales, but these two are the ones you need to know. These are the only two I've used in my career. FLAC, which is used in children usually under age 3, especially infants. FLAC, face, legs, activity, cry, and consolability. You don't need to memorize it, just know that this is the one we use in infants. I've actually used the FLAC scale on people who were coming out of surgery in my last job before I came to teaching, if they were still under the effects of anesthesia. Saying. Face scale I usually use in 3 and older, where they can kind of relate a face to how they're feeling. And I'll show you in a bit. The other ones, I can be honest, I've never used. Okay, here we go. This is flack. Again, you don't have to memorize it, look through it, just memorize the name of it. It's used in infants. Here's the FACES scale. I pulled this down, showed a kid, and I'm like, "Oh, you look like you're here, to me." And the kid would say to me, and this would break my little heart, "No, Miss Peggy, I feel like I'm here. I hurt bad." It's like, "Oh my gosh, you feel terrible." Again, I don't want to make assumptions that they're here, right? I got that child to tell me. Older kids, like eating up, we can use the traditional like 1 to 10 approach or 0 to 10, all right? Again, infants in neonates, we're going to use that flax scale. Young infants, how do they respond to pain? Well, let me show you real quick. Look, that brow is all furrowed. The eyes are squinched shut. The mouth is in a grimace. The legs and arms are usually flailing about. That's a look of pain. Okay. Here's another depiction of that. Infants, again, they will have louder cries than usual facial grimacing, that type of thing. What will help them? Here's some of your non-pharmacological measures. Is what nursing rocks the world in. Remember, an infant just came out of utero. You know what I'm saying? They're squishy. They're squished up in the uterus. So that's why they like to be swaddled, or bunny wrapped, or burrito wrapped, whatever you want to call it. They're used to being held very snugly. Non-nutritive sucking, meaning a pacifier or a nipple that's sweetened a little bit. Kangaroo care is holding them. Here's me, this is two nurses because they have gloves on. Usually parents are going to wear gloves. They've got this baby swaddled. They're giving them a source of suck while the nurse is drawing the heel stick. Personally, what would make this picture better is if this nurse was holding that baby, just like this mom is doing right here. Here's another picture of swaddling. Some people call it the burrito wrap. Makes sense to me. That looks like an egg roll too. I must be hungry. All right. How do we measure? Again, we already talked about we'll use FLAC early on, faces if the child is like 3 to 8 years old, and then 0 to 10 after that. Okay, here's kids screaming, crying. I tell children all the time, it's okay to cry. Don't let anybody tell them it's not. You can scream if you want to. Your biggest job for me is to hold still. Many times I'll tell them. And here's the assessment scale. School age children will tend to use stalling behaviors. Always cracks me up. You know what I'm talking about. They're like, give me a minute, 1 minute, wait, 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 wait. No, let's get it done. Okay. Adolescents might, they're again more adult like, but remember, they may not have had very much experience in the hospital setting. Children who are cognitively delayed are going to have their own like issues in measuring their pains. Many times I elicit the support of families. Okay, kids with chronic illness will, of course, have different pain as well. All right. So again, we're getting better at treating children with pain. That's for sure. All right. Here's again non-pharmacological for older children. Distraction is one thing we use, and largely, who can help you with this? Please, my friends, do not forget this. Call in the child life specialists. They are people that have degrees off, at least at minimum a bachelor's degrees, many times a master's degree, who understand development in children and will help you and help them with coping skills. Distraction. They'll bring an iPad in while you're starting or drawing an IV or drawing the blood. They've got the kid distracted with an iPad on the other side of the treatment room table. All right. I use counting a lot. I would tell children, okay, we're going to start the IV now. I want you to start counting to 10. If it starts to hurt, you count louder. Man, did that work. Okay, pain management, you know this. The same as with adults. All right. Pharmacological management, remember, we will use an opioid sometimes, watch their respiratory, because it can depress it as well as it can cause constipation, even in children. There's other things we can use. Here's that EMLA cream I was talking to you about. Obviously, the nurse wants to draw blood out of this area here. You put a blob of that cream down. You got to keep it in place with like a Tegaderm, right? And then after about a half hour to an hour, whether it's LMX or EMLA, then that area will be numb. So they won't feel that stick. How do I know? I ask them afterwards with the FACES scale. Hey, 0 to 10, how was it? Did you feel the needle poke? You know what I'm saying. Never ever apply that to broken skin though, all right? And make sure you use a couple sites. And it's whatever site seems best for you. All right? Okay, now we will move into chapter 22. Okay, moving onward, chapter 22. How do we do things differently as nurses for peds? Is pretty much what's this covered. First, let's talk about informed consent. You need to know this. It's like something that still kind of blows my mind. Who can sign the consent form for that child, right? They're minors. They're under age 18. Ideally, it should be either parent. But there's been situations. For example, say the parents go away on vacation, leave the child with a grandparent, the child gets hurt and it's an emergency, we can't get a hold of the parents, the grandparent can sign the consent, usually in an emergency situation. Same with, let's say the kid gets critically injured at school and the teacher rides in the ambulance with them, right? Can't get a hold of parents? The teacher can sign consent. That one blows my mind. In my whole career as a peds nurse, never had that happen, but just be aware. Another thing you need to be aware of is this consent. What does that mean? This is really difficult, you guys. What? If a kid is like 16, they might disagree with the parents' thoughts or, the parents' decision. My daughter had told me she read about a kid whose parents refused all immunizations. At 18, he booked his appointment and he got caught up to date on immunizations. That's just an example. But sometimes you might have it where family members differ, where the child differs from the adult. That will take a call to the primary care provider. Other times there might be eligibility to sign a consent. That child is emancipated. We're going to talk about that in just a second. Here, this explains assent. Understand that because it can be difficult. All right. Emancipated minor is this. It's when the child is not at the legal age of majority. They have court-ordered rights or a situation that puts them in majority. Let's talk about that. Drew Barrymore did that. Her parents were, more screwed up than her. So long story short, I think it was 15 or 16, she petitioned the courts to become an emancipated minor. In most states, this is where it won't be on our test because this is state law driven. But most states, these situations emancipate that minor, meaning children can ask you, like 16, 16 to 17-year-old, 14-year-olds, about contraceptives without their parents present or their consent. It's legal in almost every 50 states. Oh, we all know that's a slippery slope right now, isn't it? So be aware of your state thing. All right. How do we prepare them? I've already told you. Make sure you're being age specific. Very young kids want to touch it, feel it, and it needs, the treatment, the teaching needs to be done in the moment. Our book on page 680 does talk about preparing children for different procedures. All right. Remember, use those treatment rooms. Their safe place is their bedside. We do have something called a child life specialist. I've got a video to show you with that. I'll show you in class. Okay, post procedure, allow that child to express feelings. Let the child life specialist come in and help that kid with those feelings. Give them positive reinforcement. I don't care how awful that kid was. I tell them, you know what? You did a good job. You helped to hold still. Okay, next. How do we get kids to do certain things, so to speak? There are specific age specific things for procedures. Many times we make a game out of it. Okay, I want a kid to drink fluids to increase their oral fluid intake, right? What do? I can't say, here, you need to drink. That might work, but usually I'll say, hey, see if you can drink that glass of water before I come back in 10 minutes. If you do, like really encourage them, hey, you can do it, type thing. What about coughing and deep breathing? I can't give him a TriFlow. I give this little boy a TriFlow. He's gonna think it's a toy or something, right? How do I get them balls out of there? With that said, how do I get a child to cough and deep breathe? This is a pinwheel. You can use that. Don't get them deep breathing to spin this around. Make a game out of it. Put your pen light up. Here, blow my pen light out. You let that pen light go out when that kid takes some deep breaths. Bubbles we'll use too. Sometimes we kind of stay away from them. Why? They can be messy and then make slippery and slidey. This type of thing can be done by parents, so we're going to go through that relatively quickly. Here's the big component that is in nursing's realm: safety. Number one, those kids need a name band on them, especially infants and young children who are not verbal. They need to be identified. The band, that can you tell me their name and date of birth? That gets done with the parent, and I want that band on them just in case that parent, for whatever reason's not there. Okay? Big thing is falls. This little baby doesn't know they can roll off that crib. I'm telling you, you keep a hand on them at all times. Crib rails should be up. I put my weight on them to make sure that they're not going to go down accidentally. But see, this nurse is reaching for something on the bedside table, and she has a hand on that infant at all time. Safety is key. Remember our infection control measures. There's a PowerPoint within our communicable disease that talks about what it's so important that we know what type of isolation. Most kids are in isolation, I'm going to tell you. Every kid gets standard precautions just like adults, but a lot of disease factors kids can have going on, they'll need isolation. Restraints will be a little more loosey-goosey in the child world compared to the adult world. What do I mean by that? This little girl has what's called nosies on, or a little elbow restraint. You usually don't need an order updated every 24 hours like you do in the adult world. I don't if I can't have her touching her face, say she had surgery there, we'll put those on, right? We don't need usually orders, but just like my adults, this is what I need to do. I need to make sure the skin isn't getting affected by the restraints by periodically taking them off and looking at the skin. I also need to make sure, it's not impeding the circulation by checking distally. All right. So restraints in the pediatric population is different. We will put four side rails up on kids. Cracks me up. One time I did a med surg clinical. This is before I'd heard that all four side rails up is considered a restraint. I popped the side rails up on everybody. That's what we do with kids. I had a student say, "Oh, Bernie, that's considered a restraint." I'm like, "What?" But I rocked in the kid world, so I appreciated that information. Here again, swaddling is considered a restraint or a mummy restraint, swaddling, what bunny wrap, whatever. Here is a parent helping to hold with a procedure. They can help, just sometimes they're not the best at doing it, just FYI, right? How do we collect a urine specimen in children? Generally speaking, with a baggie that's kind of stuck to their bottoms. It's called a Peds urine collector, or a puck for short. Let's talk about med administration. First and foremost, this is the reason why you do med calc by weight in kilos with children. Everything that's put in a child's mouth, pretty much medication wise, is done by weight in kilos. You will notice, like with antibiotics, we do a low range and a high range. Why is that? Some infections don't require me to come out with all guns blazing, right? We'll use a lower dose. The manufacturer, researchers have found out that it's effective for minor infections at this level. If they've got like a full-blown meningitis or a very bad infection go on, we're going to come out really big and strong. So that's why they're arranged. Here's what you need to know as a nurse. If, let's say, you calculate the range, and this is what you're going to do in clinical, because we as nurses are the last line of defense to the patient. I will ask you, what's your safe dose range on that? Meaning, what's the minimum you can give? What's the maximum you can give? It's important to know why, especially like say in antibiotics. What if you calculated it out and you're like, oh, hey, Professor Kearney, it's not even hitting the minimum. It's like 400 milligrams a day too low. What should you do as a nurse? I hope you're saying call the provider because we need it to be effective, right? If it's too low, it's not going to be effective. Be up with that concept because that might be one of your math questions you see. All right. Here's a big thing about children too. Getting them ready to get the medicine. Is it okay for the parents to give the medicine? Absolutely. All right. Absolutely. Here's what's not okay. Let's say you go in the room to give the child their liquid medication and it's in a cup. And the parent says, oh, they're finishing up their breakfast. I'll give them to it afterwards. Just leave it here. What's your response? Nope. Put the call light on when you're ready. I need to make sure that they take it. Get what I'm saying? Never, ever, ever. Yes, it's fine that the parent gives that, especially an oral medication. We're not going to let them give an IM, though I've let parents give the sub-Q insulin. If they know how, they've already been checked off. Long story short, I'm going to tell you this, you guys. Never, ever, ever do I leave it for them to give later. It's my responsibility to make sure they took it. All right? Just like we do it with adults. Oral medication is the preferred route because it's best tolerated by children. IM is a good route as well as IV because those are muscles are very vascular. IV goes straight into the bloodstream, right? FYI, with given oral medication, be very careful. Push, kind of hold that infant back. This is a syringe. Usually they're amber colored, the oral syringe. We squirt the medication into the sides of the mouth, the buccal mucosa, if you will. Why? I don't want to squirt it in straight back at the uvula because the child could choke. Is it okay to give a crying baby medicine? Oh, yeah, absolutely. Why? You'll be waiting all day sometimes. With that said, children 11 months and under, they have something called a diver reflex, meaning if I blow in their face, like I'll squirt a little medicine in, blow in their face, and then they'll swallow. Try it sometime. I had a student who was like appalled. Oh my God, I'm not blowing my stinky breath. I said, well, have the parent blow their breath. Whatever. You're going to do whatever it takes to get this kid to take that medicine. Sometimes younger infants, like 6 months and under, if you take an empty nipple and like put it in the baby's mouth, get them sucking, you can squirt the medicine in. FYI, when I teach parents about giving medications at home, they're going to get a measure like they'll say teaspoons. So it might say give amoxicillin 1 teaspoon, 3 times a day. Well, there's my teaching, friends. Can they use any old teaspoon in the kitchen cupboard? Please say no. Why? You've seen those teaspoons. Some they can vary in size. They're not exact measures. They need to either get a syringe from the pharmacy or one of those little syringe type things they can purchase. Or here's if they, didn't catch that one. If they go home, you know what I tell them they can use to measure? They can use like if you guys are bakers, it has to be very precise with baking. The teaspoon measurement for baking is an okay thing to give. Typically, they need to measure it appropriately. Okay, IV fluids. The thing I want to tell you guys big time about this, hey, make sure, every kid that walks in a children's hospital or Beaumont Royal Oak, first thing we're doing is I&Os. everything that goes in, everything that comes out. We also, most hospitals write an order, a standing order, 3 and under, they're a daily wait, okay? It's so, so important that we watch their kids can dehydrate. The younger they are, the lot quicker than older kids, right? But we do INOs on everybody. Children's Hospital, Michigan, you actually have to chart an INO every 2 hours, even if it's 0, 0. Why? It's so, so, so important to follow. If is that kid urinating? If they're not peeing, it usually means because they're getting dry. So just some things to think about. Okay, there are different types of IV devices. I want to tell you this. Anything infusing in your kid, you need to check that site every time you go into the room. If it's a peripheral IV, they're wiggling around and those catheters are small and can slide out of the vein. Those pumps are relentless. They'll continue pumping fluids into their body. Okay? Um, Anyways, with that said, be very cognizant. Unlike the adults where you check the IVs, let's be honest, like once a shift or something. No, every time you walk in the room. Even if they've got a port, this needle can come dislodged if the kid is very active. Um, Anyways, with that said, I'm watching that site. They're jumping around in that bed. That needle could become dislodged and fuse under the skin. Okay. Another thing, eye drops. Eye ointments can be very difficult to give to a kid. I want you to know about this for the test. Remember, we taught you this in 224. If I'm giving an eardrop to a kid, what's the rule about the ear? Remember this. 3 and under, so if the child's 3 and under, you pull the pinna of the ear back and down. If they're 3 and over, we pull it back and then pull the ear up. That aligns the ear canals a little better. Okay, that's it.